Hey guys, welcome to this topic. We're going to talk about urine analysis, and nowadays things have become simpler because we have dipsticks available by which you can check out the sugar and the protein and the ketones and even the presence of blood in urine. But then most of the time in the exam, they love to ask about proteins. So I'm going to start with this. In a textbook or in routine discussions, they talk first about specific gravity and pH of urine, but that's something that's more asked in medical college in competitive exams because they mainly focus on proteinuria component, especially because kidney parenchymal disease is associated with proteinuria. So we're going to handle the core issue at the moment, and the message at the moment is that dipsticks are very good for picking up negatively charged proteins like albumin in the urine, but they will not be able to pick up positively charged proteins. Positively charged proteins would be called as paraproteins. In condition like multiple myeloma, there's a possibility that the dipstick might be false negative because the dipstick is designed to pick up not positively charged proteins but only negative charged proteins. With this, the query that would come up is that do we have proteins in urine of a normal individual? The answer is definitely a yes. How much is the protein which is present in a urine of a normal individual? Then the magnitude would be in the range of less than 150 milligram on a daily basis. Some of this is going to be coming by the glomerulus, some of this is going to be coming by the tubules. When it comes to the glomerulus, the major protein that would be coming is albumin. The amount of this would be usually less than 30 milligram per day, which means that the remaining 120 milligram is going to be coming from the tubules. So the protein that would be coming from the tubules is produced by the cells of the ascending limb of loop of Henle, and they are the ones which would be called as TAM Horsfall protein. In fact, either the MCQ will use the word TAM Horsfall protein, and an alternative terminology that you will see is uromodulin, and this will constitute the remaining 120 milligram. So you add it up, this would be 150 milligram or lesser in a 24-hour period. The disadvantage with this technique would be that you will have to collect 24-hour urine sample. Easier said than done, because when you tell a patient to collect 24-hour urine sample, either there is a under collection or there is a over collection. So therefore, to bypass this problem, what we started doing was we started estimating albumin in the spot sample. Now, when we evaluate the albumin in the spot sample, in the numerator, we are obviously going to incorporate urine albumin. But in the denominator, it's not 24-hour day, that's a 24-hour entire amount of protein. But in the denominator, what is present is urinary creatinine. So what I'm teaching you at the moment is called as albumin excretion rate, or is called as urinary albumin creatinine ratio. This would be expressed in milligram per gram of urinary creatinine. So I can just put up a value here before you for exam purposes. Lots of time when cardiovascular mortality is mentioned or diabetic nephropathy is mentioned, this term will always be written that a person of diabetic nephropathy is having approximately 30 to 300 milligram of albumin. I mean, as compared to normal, it's almost 10x when it comes to albumin component per gram of urinary creatinine. Now, why am I highlighting this statement is because when I used to speak about this particular value that I've written on the slide at the moment, a couple of years earlier, I used to use the term microalbuminuria. But currently you would have seen that they have withdrawn the term microalbuminuria, and the current literature rather supports the word moderately increased albuminuria. I repeat my statement. In earlier times, we used to call it microalbuminuria. Now we call it a moderately increased albuminuria. And I also enumerate causes why this would be happening, because they can ask you regarding moderately increased albuminuria, and then can also talk or ask you regarding what I can say as severely increased albuminuria. So we will be definitely making a list here, because in version 2 or version 3, you will notice I would have been talking about a test by the name of urine micral, because that's what we used to write on the prescription slip, urine micral, and the laboratory guy used to understand that the doctor wants to check out for the presence or absence of microalbuminuria. But currently I have told you what the literature supports, and one of the very important part of this discussion is that in any patient who's having the following amount of albumin present per gram of urinary creatinine, this indirectly implies that cardiovascular mortality is going to be increased in this individual. He can develop a MI or any of the components of acute coronary syndrome that I've discussed in the cardiology section. Now, why can it develop? Then one of the leading causes for this would be diabetic nephropathy. In fact, this is a separate discussion in the kidney section, and I have mentioned at that point of time that the screening test that you do to identify diabetic nephropathy is not serum creatinine. It's not going to be creatinine clearance you calculated by MDRD formula, or let me say the Cochrane Gold formula. If I want to identify diabetic nephropathy early, I need to identify this by checking out the urinary albumin creatinine ratio or albumin excretion rate. If this is elevated, that means damage has already occurred in the kidney and low dose ACE inhibitors need to be started to prevent further deterioration. Another important cause of this could be hypertension. It's an examiner's decision whether he wants to write plain hypertension or he wants to write malignant hypertension. Malignant hypertension, why is it called malignant? Because traditionally cancer is called malignant, because in malignant hypertension, the 6 to 12-month mortality rate can be as much as 50%. If you label somebody as malignant hypertension based on target organ damage, eyes are involved, there's retinal bleeds, there is aorta involvement, there could be kidney involvement. So hypertension anyway is a silent killer, you very well know that. So if it's gonna be multi-system damage, the mortality rate can go up to as much as 50%. In fact, in earlier times when we did not have ACE inhibitor, the mortality rate was 90%. 6-month mortality rate for malignant hypertension was 90%, but we can identify malignant hypertension developing, and we can obviously identify routine hypertension developing if we are able to pick up this particular magnitude of albumin per gram of urinary creatinine. And then all the varieties of glomerulonephritis, whether it's gonna be RPGN, PSGN, obviously some of them have a good prognosis, but ultimately in some of them there might be permanent damage. So I can broadly say the term chronic glomerulonephritis. If that's gonna be a renal parenchymal disorder, you're gonna have moderately increased albuminuria. On the other hand, let me say, if I increase the value here, like let us assume that the magnitude of proteinuria here is from 300 to 3500 milligram, you are very well understanding that I am leading you to nephrotic range proteinuria, which is more than 3.5 grams. But at the moment, what I'm saying is, if it's gonna be lesser than that threshold of 3.5, it's from 300 to 3500 milligram per gram of urinary creatinine. I'm just writing U.C to stand for urinary creatinine. I'm gonna say that the person is having a severely increased albuminuria. The cardiovascular mortality in this case will even be higher, and I expect you to tell me causes why this would be happening. Well, as far as the causes are concerned, cause number 1, 2 and 3 that I've written on the slide already, diabetic nephropathy, hypertension, glomerulonephritis, they very much will be present. But over and above this, other conditions which could be contributing to this can be, for example, multiple myeloma. You very well know that in multiple myeloma, it will be positively charged proteins in the urine. So instead of writing multiple myeloma, lots of time they write the word paraproteins. I have already sensitized you to the fact that if they're positively charged, then the dipstick will turn out to be negative. That is why, though dipsticks are very comfortable, I deliberately began with a situation where dipsticks can be false negative. In fact, I'm writing at this moment this particular value of about 300 to 3500 milligram, and you very well know total serum protein is 6 to 8 grams. So can you tell me a medical condition where a person can be having as much as 10 grams of protein loss in the urine? Normal is 6 to 8 grams. I'm saying 10 grams. 10 grams would imply much more than what is present in the blood. That can happen only with multiple myeloma. So there's a format of multiple myeloma or a precursor that is called as monoclonal gammopathy of unknown significance. So what I imply in this particular case is obviously multiple myeloma in initial phases or MGUS. Any of the two could be present to cause protein in the following magnitude that I've described. But as the disease increases, the plasma cells continue to increase, the clonal expansion of plasma cells occur, there's a plasmacytoma, the amount of proteins can increase to as much as 10 grams per day. Apart from this, other causes which could be responsible can be presence of high-grade fever. In fact, I would also like to tell you that whenever a person is supposed to give a sample to the laboratory for protein estimation, you must tell the patient, sir, on that day avoid going for a morning walk, and most importantly avoid any kind of running or jogging activity. because studies have shown that even mild to moderate form of exercise, I'm not talking about a bench press or twice a body weight, some kind of heavy duty weightlifting. I'm just saying that even mild to moderate level of exercise by individual on the particular day when the testing is being done can actually cause the protein value to be falsely elevated. So you definitely need to keep both of these things in your mind when you're evaluating a report like this. And then a very surprising data that I'm telling you is orthostatic proteinuria. Well, the surprising thing here is that there would be proteins in the urine of this patient when he is standing. But when he's gonna lie supine, like you give him a bottle and lying down, you're asking him to urinate, which is obviously difficult. But you will notice that when he's flat, the proteinuria tends to disappear. When he's standing and is delivering a urine sample, the proteinuria definitely can be present. So these are a couple of aberrations that are to be kept in mind. Like when you are saying somebody that I think you are having a increased cardiovascular risk, it's a big thing to say that to somebody, right? So before you say that I think you have an increased cardiovascular risk, you must take into consideration that was there a fever present for a few days before the sample was taken? Is this person a heavy duty regular gym goer and he does weight training, or is this guy even having a presence of orthostatic proteinuria? So I mean, you definitely need to interpret this report with a word of caution. Now, anything more than 3.5 would anyway be nephrotic range proteinuria. Nephrotic syndrome is discussed separately. So we need to incorporate a couple of more terms so that things become relatively easier for us to understand. The next term that I'm going to say before you is not going to be from the quantitative perspective, but the MCQ that was asked said overload proteinuria. Now, let's look at what he means by the word overload proteinuria. One is obviously paraproteinemia. Multiple myeloma is coming up here as well. You will notice that in the entire discussion, every time I'm talking about proteinuria, these positively charged proteins will come in the picture, because at the moment what I'm speaking is incomplete light chains. That is Bence-Jones proteins which are coming in the urine specimen of the person. So there is a overloading of the kidney tubules. Next could be a precursor of this monoclonal gammopathy of unknown significance. Then can be a chap who's crossing the road, a truck went over his legs. It crushed the legs of this guy, so it can contribute to development of myoglobinuria, and this chap would be passing red color urine. Yes, rhabdomyolysis causes red color urine, and there would be presence of myoglobin in the urine. So myoglobinuria is again a situation where there's an overload proteinuria. The next person, he is having rather, let me say, a mismatched blood transfusion, or is having medical conditions like PCH, paroxysmal cold hemoglobinuria, paroxysmal nocturnal hemoglobinuria, discussed in the hematology section. So the hemoglobin is present in the tubules. That is definitely abnormal. It's overloading of the entire system. So when you read about overload proteinuria, it's not about quantification. It's rather gonna be the causes which I've highlighted here before you. Then, as I said initially, that even heavy duty exercise, fever can contribute to development of proteinuria. So you need to interpret the reports on the previous page with a bit of care, and therefore he's used another term, functional proteinuria. Functional proteinuria simply describes what I said earlier. I mean, if a person has done a bit of exercise, jogging, then the urine sample might be falsely positive. So just to discriminate between a pathological one versus something which is related to something innocuous like exercise, another term has been discussed, that is functional proteinuria, because half the time they trouble you with these technical terms. So I thought I'll just mention them before you. The next entry that we'll be discussing would be obviously what everybody loves to ask, nephrotic range proteinuria for adult. This you guys can contribute here. I mean, please do not answer minimal chain disease. I know, I mean, you very well know about minimal chain disease. That's from pediatric perspective, right? So can you tell me a adult patient who's, let me say, having bilaterally enlarged kidneys, pale waxy kidneys, and is having nephrotic range proteinuria? Yes, guys, I would be waiting for your prompt. I very well know it's a recorded class, but just to give a semblance of a live class, just to make it more interactive. Yes, guys, what do you think would be responsible for pale waxy kidneys, bilateral enlargement, and nephrotic range proteinuria? Well, you guessed it right. One of the important causes can be amyloidosis. Then the number one cause for nephrotic range proteinuria in adult population is definitely not minimal chain disease. It's not that minimal chain disease cannot occur in children. I agree. Minimal chain disease, lipoid nephrosis, those are the terms that he will use, can occur in adult population also. But from the internal medicine perspective for adults, the first answer of yours would be given as diabetic nephropathy. Then other causes which I expected you to say was important cause of nephrotic syndrome in adults, focal segmental glomerulosclerosis. Then is another cause of nephrotic syndrome in geriatric age population, that is membranous glomerulopathy. Yes, the one which is also associated with renal vein thrombosis. In fact, this is itself a question, just like you're aware from pediatrics domain that renal vein thrombosis in children is related to diarrhea and dehydration. In adults, it is related to membranous glomerulopathy. So you need to be familiar with these terminologies that I've highlighted before you. A nephrotic range versus moderately increased proteinuria versus a severely increased proteinuria, and the microalbuminuria term is not used anymore. In earlier time we used to say micral, urine micral is a screening test. Now we'll be using the terminologies which are mentioned here. And let's now look at the urine sample of a person who is having a substantial amount of protein present in the urine. You will always notice that the first morning urine sample can be slightly foamy. But if you collect the first morning urine sample in a test tube and let it stand for 15 minutes, you will notice that the foam will tend to settle. But in nephrotic range proteinuria, this foam will not settle. Like what I am showing you at the moment is that the person has urinated, the sample is present in this beaker for 15 minutes, 20 minutes, but the foam has not settled. So whenever a patient is saying the word foamy urine, I agree to the fact that the first urine sample can be foamy as well, but then I explained to you that it should settle. So foamy urine, if written in a multiple choice question or complained by a patient, you must take into consideration a substantial amount of proteinuria present in this patient, and that would be to the range of nephrotic range proteinuria. Another aspect which I want to just say at the moment is urine turns yellow on air exposure. Very simple fact-based question. Like I'm not talking about urine turning black on air exposure. Alkaptonuria, everybody knows. Urine turns yellow on air exposure. Why was the question? Because you see, when the urine is freshly passed, it will always appear almost transparent. But then if you keep it for a few minutes, it would turn relatively yellowish. So the component which is present here should be answered as urochromes. Yes, they are normal components present in the urine and they're responsible for this color change. And I just want to highlight once again, if you read a question where almost 10 grams of protein are present in the urine in a 24-hour period, and the dipstick of the patient is negative, then you always have to think in terms of that the fact that the dipstick is false negative. I already sensitized you to that, and that was again one of the scenarios that was mentioned, because Bence-Jones proteins cannot be picked up with help of a dipstick. So what I'm going to do in this case is that instead of trying to waste my time by checking out Bence-Jones proteins by heating the urine sample, because you know traditionally Bence-Jones proteins, they precipitate at about 45 degrees Celsius, and if you continue heating the urine sample, they will tend to disappear by 55 degrees Celsius. That's what they teach in medical college, but that's a very primitive method of identifying it. So how would I be identifying that there is paraproteins present in the urine sample of the patient? The reason I've written para word outside this box is just to sensitize that initially I was not aware that it is positively charged protein, but the test that will tell me here can be either a serum electrophoresis or a urine electrophoresis. That would help you identify. You very well know M spike on urine electrophoresis helps you identify multiple myeloma. In fact, this is one of the easy screening tests that you could be using for these patients, and multiple myeloma has been discussed in detail in the hematology section. A related MCQ at this point of time, and I can put that as a question to you guys. Can you tell me a autoimmune condition related to the brain, more common in women, where you have Uthoff phenomenon and you read about CSF electrophoresis? You will read oligoclonal immunoglobulin G bands present in the CSF of the patient. This is a miscellaneous question that I'm discussing at the moment. Just like you guys are comfortable with urinary electrophoresis producing a M spike for multiple myeloma paraproteins, I think all of you are comfortable with the fact that the autoimmune disorder that I'm asking you here, where you get Uthoff phenomenon, where the neurological symptoms appear on heat exposure, on exercise by a patient, is presence of multiple sclerosis. So two related questions here, urine electrophoresis and CSF electrophoresis for this information. So what I will do next is just jot down the information with respect to the dipstick interpretation for the urine that you're gonna test. You will lots of times see these reports written like trace protein present or 1+, 2+, 3+, 4+. So let us just signify and quantify what these values actually mean. Trace protein would mean that the magnitude of protein in the urine is in the range of about 15 to 30 milligram. 1 plus you have to just increase slightly to 30 to 100. 2 plus is going to be 100 to 300. That is what I was initially talking about as a moderately increased proteinuria in a patient. 3 plus would be slightly more, that is going up to about 1 gram. And if it's going to be more than 1 gram, then the dipstick would rather be giving you a report of 4 plus. So this is just interpretation of the dipstick that you should also try and remember, though most of the time it is that urinary albumin or creatinine ratio or the albumin excretion rate, which will mostly be written in most MCQs, including when you listen to the discussion of chronic kidney disease. You will notice I have graded chronic kidney disease from G1 to G5, and then I've also mentioned regarding albuminuria values as A1, A2, A3. So I think that the reason why I have started with protein is more justified, because renal parenchymal disorders, proteinuria always indicates a bad prognosis. The next thing that we're going to study in this discussion is with respect to RBCs in the urine. So when I'm going to be jotting down this information, what I'm going to ask you here is that do you have RBCs in urine of a normal individual? Well, the answer would be yes. We do have RBCs in urine of a normal individual. If he says how much, then I'm not saying that you're going to take a urine specimen and you take 1 drop of it, see under microscope, and you can see RBCs. What I'm saying is you take a urine specimen of a patient, freshly passed morning sample, and then you spin it, you centrifuge it, and then in the sediment, you will be able to see less than 3 red blood cells per high power field. So we do have red blood cells in urine of a normal individual. However, he has asked what is the definition of the word hematuria. You will say if you are able to document more than 5 RBCs per high power field, not once, at least 3 times, I mean that's the technical definition. If you are able to demonstrate at least 3 times that the magnitude of RBCs is more than 5 RBCs per high power field, and this should not be like Monday, Tuesday, Wednesday, it should be at weekly intervals. So you are able to prove that yes, the person is having presence of hematuria. I would say the criticism for this definition is that you're gonna wait for 3 weeks to tell somebody that you're having hematuria. Can't you check it out in single spot specimen and tell the patient yes or no, are you having a hematuria? So if he says in a single specimen, mark my words there, in a single specimen, more than how much cutoff should you be saying to say that this person is having hematuria? Then it would be more than 100 red blood cells per high power field of the centrifuge specimen. So both the definitions, any of the two can be asked, and I think I've made myself clear that you do have red blood cells in urine of a normal individual. But if you read this term dysmorphic RBCs, which means that the RBCs are having a change in the shape. Now why is that happening is because they have to get filtered through the damaged basement membrane. So whenever you read this term dysmorphic red blood cell, or if you read the term RBC cast I'll be mentioning subsequently, so I'm not writing down the word RBC cast, but the moment I say dysmorphic RBC, the moment I say RBC cast in a patient, what should always come in your mind in the following words: glomerular bleed. It could be immunoglobulin A nephropathy, it could be various forms of glomerulonephritis that you see, but dysmorphic red blood cells / RBC cast, because these RBCs will go and stick on the surface of thymophosphol protein. So you will always be getting an indirect hint from the pathologist's office that the glomerulus is at fault in the patient. If he says what is the number 1 cause of gross hematuria, then first do not answer, the word is not answer renal parenchymal disorder. The number 1 cause for gross hematuria should be answered as urological causes, which means that there could be a kidney stone, it could be ureteric stone, it could be a bladder stone in a person. The edges are jagged, and those jagged edges could cause local erosions, and therefore bleed could come. In 90% of the cases, it is urological causes, and if they have been ruled out, like let me say cystoscopy is clean, CT abdomen of the patient is normal, you got these basic investigations done, there is no pathology found per se in either the ureter or in the kidney or at the pelvic-ureteric junction or even in the bladder, then you definitely need to consider renal parenchymal causes. So the first impression, because we are discussing kidney from the medicine perspective, is that whenever there's gonna be a question on hematuria, it's gonna always talk about glomerulonephritis. That is not the case. First would be rather surgical causes. Stones are to be remembered as a predominant urological cause. But my next statement has to be listened very carefully, and this is totally, I would say, in contrast to what I have said right now, which is that if the MCQ talks about microscopic hematuria, then the answer is not to be given as urological. So let me just elaborate. This person, he is, let me say, 40-50 years of age. He underwent an annual medical checkup, which was mandatory from his company's perspective. Like after COVID, you will notice that all corporate companies are always asking their employees to keep their medical status updated, and most of the time go for annual medical checkups, because that helps them screen out people who are having medical disease, and therefore they can adjust their premiums. But the point is, this particular chap, when he got his report done, it said that there is, let me say, 20 RBCs per high power field. So he came to me with that report. He said, "Doctor, is there something wrong?" So I called up the lab and I said, "You have given this report. Did you double check?" They said, yeah, sir. We have good quality control system. I have double checked, sir, and it's like 20-25 RBCs per high power field. So I said, okay, let us repeat the sample. I've repeated the sample a couple of times, and there is like 25, 30, 50 RBCs always present in the urine of this patient. And he's asking me, "Sir, I mean, what is going on?" Incidentally, while these consultations are going on and I have not given him a conclude answer, let me say the season is changing, winters are coming, and this guy acquired a viral URTI. Following a viral URTI, because the mucosal immunity will kick in, the IgA levels in the body of this person will increase. And then what happened was very striking. In as little as 48 hours after starting of a respiratory tract infection, that to a simple URTI, routine khansi zukam, this particular chap has upgraded from microscopic hematuria to gross hematuria. If you get a clinical history like this, where he says that a person who was already under your follow-ups for microscopic hematuria, post upper respiratory tract infection, he has upgraded from microscopic hematuria to gross hematuria. What is the first differential that you will consider? You have checked out the blood pressure of this patient, normal. You checked out the complement levels of this patient, perfectly normal. There is no evidence of inflammation in the kidney. There is no itis, there is no glomerulonephritis, but still what you are finding is that there is a gross hematuria. Then the diagnosis is to be considered as immunoglobulin A nephropathy. Guys, this is one of the leading causes of development of microscopic hematuria. These patients most of the time are not even aware of the fact that they are having RBCs in the urine, because mostly in India nobody will go for an annual medical checkup. So these cases are picked up incidentally, and every time they will have a respiratory tract infection, they will upgrade to gross hematuria, and after a few days, because when he will recover from URTI, IgA levels will reduce, he will downgrade from gross to a microscopic hematuria. Those steroids have also been used in Burgess disease, but they are of plus minus value. So this upgrade and downgrade continuously happens over the entire lifespan of a patient. I mean, this is a very classical presentation of what you read as immunoglobulin A nephropathy, or is also referred to as Burgess disease. Now, the next perspective that I would like you to remember for hematuria would be a person who's passing a red color urine. In fact, I can put this up as a question to you guys. Can you tell me a drug intake of which on a regular basis in a patient due to an infective cause can contribute to passage of red urine? Well, you guessed it right. It is definitely not rifampicin. Rifampicin causes an orange discoloration of the urine. Your answer would be an anti-leprosy drug. That would be clofazimine, that causes a red color urine. Obviously, this guy is not taking any beetroot, which can contribute to red discoloration lots of time. This person is also not having porphyria of various varieties, and there are no porphyrins in the urine of this chap. So whenever you are having red urine, you must always consider two important causes that I have mentioned. And apart from this, I can say that let us say another possibility, that the red urine of this person was tested by dipstick and it turned out to be positive for presence of RBCs. There's presence of blood in the urine. In those circumstances where the red urine is primarily because of the blood in the urine, what you are supposed to instruct the laboratory is that they should be centrifuging this urine sample at about 1500 RPM for 5 minutes. And why am I doing that is because on centrifuging, what will happen is that the RBCs will tend to settle down, and I will be able to evaluate the supernatant. And if there is genuinely RBCs present, you see, initially I'm saying I'm suspecting that there are RBCs present because the dipstick is turning out to be positive. But what I am to be sure checking out is the supernatant here, and because the supernatant has become clear, this implies the fact that this was definitely a case of hematuria. RBCs were the ones which were documented. But suppose you have done this activity, but the supernatant is still red. I mean, a person came to you with red urine, you checked out by dipstick, it's turning out to be positive for presence of blood, you centrifuging it, but it's not getting cleared, there is no RBCs present, the supernatant is still red. Then what are the differentials which are possible is to be remembered. There could be two proteins which could be causing the urine to be red. One could be myoglobin, second could be hemoglobin. So I have already given you the situations for myoglobinuria. That's gonna be crush injury, rhabdomyolysis. I've already given you a situation for hemoglobinuria. It could be mismatched blood transfusion, paroxysmal cold hemoglobinuria, paroxysmal nocturnal hemoglobinuria. So now, how would I differentiate that whether this red supernatant is because of myoglobinuria or hemoglobinuria is based on the fact that the half-life, or I would say the lifespan of myoglobin is relatively short. If you keep this urine sample still in a test tube for 3 hours, you will notice that in myoglobinuria there will be clearing of the test tube after 3 hours, but with hemoglobinuria the color would remain the same. What you have learned here is two separate aspects. One is if you want to pick up hematuria, one is obviously a dipstick, but to be 100% sure, what you can do is centrifuge the sample. If you get a clear supernatant, yes, the RBCs are settled down. If not, if the sample still remains red, there could be two possibilities, and considering myoglobin having a short half-life, clearing of the urine sample would be seen within 3 hours is one of an important aspect which can be asked in a longish clinical STEM question. But if you get this particular part of this discussion right, then I think that you will be able to answer a question related to false positive dipstick for blood in the urine correct. Then we can be having RBCs in the urine even in patients who are having a UTI. It could be a plain UTI, it could be a complicated UTI. So let me just jot it down, though the next information that I'm going to say is very simple and very straightforward. I said you are getting a question in which there is information given of, let me say, a postmenopausal female, and she could be having recurrent episodes of UTI which is contributing to pyuria, bacteriuria, and even there is a hematuria. So yes, the message is that you can be having hematuria even in a urinary tract infection, and if the kidney is involved, I'll call it a complicated UTI, that is a pyelonephritis. If you read a question which mentions combination of hematuria with RBC casts, it further gives credibility to the fact that you are dealing with a case of glomerulonephritis. If RBC casts are not given, I have already told in the earlier part of the discussion, he is always going to talk about a glomerular bleed by describing the word dysmorphic red blood cells. Then another cause for hematuria can even be parasitic infestation. So I am going to describe a situation before you which is referred to as Katayama fever. I'll show you a slide for the same also. From your knowledge of microbiology, you would have anyway guessed about what am I talking about. This particular patient is having a worm living in the vesical plexus. So he is having fever, he is also having hematuria, there is blood in the urine of this guy, and this is primarily because of schistosoma hematobium. And what they mentioned in the exam was, or there was a image based question that students actually hand drew before me post exam, showing me the egg of schistosoma hematobium. And once I show you the shape, you would recall that you have already seen this in your microbiology discussion, that this would be having a terminal spine present. So you can just remember if you are comfortable with this. Otherwise, whatever the microbiologist has told you is more than sufficient. A mnemonic by the name of TSH, that terminal spine is what you encounter with respect to schistosoma hematobium. There are a couple of other varieties also for these parasites. So for other varieties like Japonicum, I would request you to refer to the microbiology section. The next information that I say is again important, because this is what is usually going to help you with those long clinical STEM questions, that is eosinophiluria. I mean, we read about eosinophils in the blood, but when you read about eosinophils in the urine, it's a little rare. So let me just give you a clinical history here, and let me see if we can pick it up. This chap, he's undergoing a coronary angiography. For coronary angiography, you can take a femoral route, right? You can have a transradial route, and your guide wire is going up from the femoral artery into the iliac artery, then into the abdominal aorta and upwards. So when the guide wire is going up, it is rubbing against a atherosclerotic plaque in the abdominal aorta or in the descending aorta, and when this guide wire will rub against this atherosclerotic plaque, it will cause the fragments of this plaque to disseminate downstream into the renal arteries. These plaques, which are now fragmenting, the fragments of the atherosclerotic plaque can cause blockages of the branches of the renal artery, causing a complete renal shutdown in the patient. The bad news is that you were trying to do coronary angiography in somebody and you have caused a renal failure. Well, the clinical history that I'm talking about here is of, and is discussed in the kidney section anyway, is atheroembolic kidney disease. Now, a lot of guys, they may not be able to remember all the details that we are discussing. So lots of times students tell me that, sir, don't we have a shortcut to remember how to answer atheroembolic kidney disease question? Then yes, eosinophiluria will always be written in every MCQ, atheroembolic kidney disease. The message here is, it's not that this guy is having a diabetic nephropathy and then I did a coronary angiography and he landed with a contrast-induced nephropathy. In contrast-induced nephropathy, creatinine is already increased, and in somebody who's having a damage to the kidney, if you give a full dose contrast, the kidney will anyway fail. There would be contrast-induced nephropathy. Prior to the procedure, his kidneys were working as good as yours and mine. But post coronary angiography, I want to highlight this fact. Post coronary angiography, the serum creatinine of this patient is showing a doubling or a tripling. This is seen only with this, but and he'll obviously describe that there is even presence of, let me say, purpuras all over the body of this patient, because these atheroembolic fragments would spread everywhere in the body. So if he gives you information like there is development of gangrene in the toes, because these fragments can go and can block a digital blood vessel also. So if he gives you a history of even development of gangrene in the toes after this procedure, development of purpuras all over, rash all over, cool, that's relatively easy. But even if he just says that post coronary angiography, suddenly the KFT of the patient has become deranged and pre-existing kidney damage was not present, you have to think in terms of atheroembolic kidney disease. It is discussed in renal failure topic, and eosinophiluria will one of the findings given in microscopic examination. You have noticed at this particular junction that I could have talked about eosinophiluria even with respect to schistosoma hematobium, because after all it's a parasitic infestation, no? So studies have definitely shown even eosinophils in the urine with respect to schistosomiasis, but the amount is not very substantial or significant to be picked up by I would say pathologist. So it is rather a substantial eosinophiluria which is sufficient in magnitude to be picked up, is what you encounter in atheroembolic kidney disease. The second scenario where you will always read about eosinophiluria is that this person has received antibiotic. Let me say he had a Staph aureus infection, CA-MRSA, and he was put on vancomycin. And post vancomycin or any cephalosporin, he has undergone a development of acute kidney injury. I am not saying that person was taken or was given streptomycin, amikacin, natilmycin, tobramycin. I'm not talking about aminoglycoside toxicity, I am talking about plain antibiotic being given and then subsequently there is an acute kidney injury, and the MCQ will always mention regarding eosinophiluria. The condition to be remembered here is allergic interstitial nephritis. Guys, I'm giving you a quick hack to solve these long stem questions for these particular topics. You definitely can spend hours studying these two topics and still fail to identify it. But what I am saying here is one of the core informations that you need to remember: a derangement of KFT, development of gangrene or maybe purpuras all over, antibiotic induced kidney injury, and that's not aminoglycosides. Then both of these questions, which would be long stem questions, because he's going to invest a lot of time describing AKI features, he's going to describe deranged KFT, but one of the common features that you will always encounter will be urine microscopic examination finding of eosinophiluria. In fact, the information that I have said at this point of time, I'll rate this information as the most critical information of this entire video discussion that I'm taking before you. And now we will have a look at a couple of images over and above the terminal spine of schistosoma hematobium with respect to this worm residing in the vesical plexus. And you can see in the image that I am zooming in at the moment, what I am showing is presence of oval fat bodies. These refractile bodies are not red blood cells. This is not a RBC cast. I'll show you a RBC cast image also. These are oval fat bodies, and where do you encounter oval fat bodies? That would be nephrotic syndrome. Now, before I write it down, I want to show you another image in which what I'm showing before you in the urine sample of this patient is a Maltese cross appearance. In fact, this is a question to you guys. What routine kidney disease do you study where you can be having a Maltese cross appearance with respect to the urine? Maltese cross in a peripheral smear is a separate MCQ, but Maltese cross appearance with respect to a urine in a patient. And why I'm saying this is primarily because of this peculiar infrastructure which is present here. I'll just remove the markings so that the original image you can have a look at, though this is magnified many times, so it's a little blurred, but the message is Maltese cross appearance in the urine of a patient. So let's jot down some information here. First one would be for oval fat bodies. This would basically imply that there is lipiduria, there is fat coming in the urine of a patient. Now, where do you read about this is first time with respect to nephrotic syndrome. So in nephrotic, you definitely read about proteinuria, 3.5 grams or more, but you also read about lipids being elevated. Patients of nephrotic syndrome have accelerated atherosclerosis, and this fat could be present in the urine of the patient as well. Another situation which I've discussed in respiratory system, where we can read about oval fat bodies, and we have also read about fat droplets in the sputum of an individual, is about this chap who was driving a heavy duty bike like a Harley Davidson. The bike fell on his leg, he had a fracture of the femur and subsequently developed fat embolism syndrome. When you will read about the GERD criteria for diagnosis of fat embolism syndrome, one of the features that I mentioned is there could be fat globules detected in the urine and in the sputum of these patients. The third cause for this could be chyluria. What is chyle is I would say a digested fat with lymph, and this digested fat with lymph is having chylomicrons. It is again loaded with fat, but if the thoracic duct is blocked, the thoracic duct could be blocked by worms like filariasis. Or if it is not blocked by worm, there's a possibility that the thoracic duct which is traveling to the chest is compressed by mediastinal lymphadenopathy. Mediastinal lymphadenopathy is what you read with sarcoidosis and silicosis. So the message is sarcoidosis, silicosis, worm infestation like filariasis can cause chyluria, and because there is fat in the urine, there could be a description of oval fat bodies. What I also described here before you was, rather I would put this again as an important discussion here, that is Maltese cross appearance with respect to the urine. You will read about MCQs with respect to Maltese cross appearance with respect to peripheral smear also, though there's an image already you can see, and I think you know the answer also, but still we'll put it up on a discussion here. And Maltese cross appearance, the third MCQ that you read is with respect to the cerebrospinal fluid. So let's look at the causes there. The first cause that you need to remember for Maltese cross in the urine, in fact, I'll tell you two of them. The first one to be remembered here for Maltese cross in the urine is nephrotic syndrome. Yes, guys, nephrotic syndrome, you not only read about oval fat bodies, but you also read about Maltese cross appearance in the urine. The second important cause for Maltese cross in the urine would be Fabry's disease. Now this is definitely an inborn error of metabolism, so it will give a lot of leverage to the examiner where he will try to put up the concept of gene here. You very well are remembering that for genes you anyway need to cram the name. So this would be GLA gene, this would be coding for an enzyme which is deficient here, that is alpha galactosidase deficiency, contributes to Fabry's disease where you have angiokeratomas. These are painful lesions in the extremities of a patient, and these are two important reasons for Maltese cross appearance in the urine. If it's gonna be Maltese cross on a peripheral smear, this is the image here, you can definitely see, or you can notice these four components which are fairly prominent, then this would be a differential diagnosis of malaria, and the condition that we're talking about is called as Babesia microti. In fact, in the exam, just to see that you are able to crack this even from I would say microbiological perspective, the question that came for Maltese cross of the peripheral smear, they did not ask the organism. They said what is the vector for it. The vector is ixoidus, that happens to be a tick. Then is Maltese cross appearance in the CSF. Well, this is covered even in topic of AIDS, that is this person is having an opportunistic infection, that is cryptococcal meningitis. So the information which has been mentioned at the moment on the slide, I would like to rate eosinophiluria, and multi-scross appearance as one of the two most important topics that I would like you to remember for this particular discussion. The subsequent information that I'll be explaining to you, however, is relatively easier and there are lesser questions expected on this. Specific gravity of the urine would be in the range of 1.020 to 1.030, and anytime if a person is having dehydration, then the specific gravity and the osmolality of the urine will increase. You see, sometimes he will use the word urine osmolality, sometimes he will say specific gravity, two different ways of measuring, I would say, the concentration of the urine sample. Urine osmolality oscillates between 100 to 900 milliosmoles, though these values can vary between different textbooks. Isocynuria, as you are aware, basically means inability to concentrate the urine sample of the patient, so the osmolality will remain equivalent to that of the plasma. What could be the reason for it? One could be that there is a chronic tubulointerstitial disease. Then could be sickle cell anemia. In fact, point number 2, most people are able to answer for isocynuria, because even in the topic of sickle cell anemia, it is taught that sickling crisis, the RBCs are sticky, so mainly the damage would be occurring at the level of the tubules, and tubules are the ones where water reabsorption occurs. So if the tubules will malfunction, the kidney cannot concentrate the urine. That's what I wrote, inability to concentrate the urine specimen of the patient. In fact, I'll just write the full word here, so that, because CONC looks a little I would say disconcerting and difficult to remember, so I just put it out, inability to concentrate the urine, and urine osmolality equal to plasma osmolality all the time is two important reasons for isocynuria have been mentioned. Specific gravity also helps you. I mean, one of the advantages of specific gravity or urine osmolality is that it also helps you to differentiate between pre-renal cause of renal failure versus the renal variety. Because in pre-renal format, because there will be dehydration, hypovolemia as a trigger, therefore the urine will become concentrated, specific gravity and osmolality will be higher. But in the renal variety, if the tubules are damaged, then concentration will not occur and the urine osmolality will be on the lower side. So this test, though not written, helps you also to identify regarding the pre-renal and the renal variety, and whatever I said verbally is already given in the acute kidney injury discussion. Then are aspects related to the pH of the urine. So there's a wide range here. The urine of the patient, the pH can oscillate anything between 4.5 to almost 8.0. And the probable question that he can simply ask here is that when is it possible to have the pH of the urine to be persistently more than 5.5? One condition where this could be possible is that there is a proximal convoluted tubule damage. Proximal convoluted tubule is responsible for absorption of bicarbonate. Now, if bicarbonate will not be absorbed, I'm using a very peculiar term that you don't read routinely, bicarbonuria. So if you're going to be having bicarbonate in higher concentration in the urine, the pH will be on the higher side. This is what is called as renal tubular acidosis type 2. In contrast, if the distal convoluted tubule of the kidney is damaged, then the manifestation would be inability to acidify the urine. If you just focus on the English words here, inability to acidify, I mean, you are supposed to add protons to the urine. If you cannot add protons to the urine, then the urine pH can definitely remain elevated. This time the damage is in the distal tubule. So I'm talking about renal tubular acidosis type 1, and RTA is anyway a separate topic which is handled subsequently in the app. The next thing that I'll talk about is aspects related to the color of the urine. This is, I would say, the easiest part of this entire discussion. Let us say the person is having, let's use some, instead of traditional things, let's talk about a fancy stuff. Patient is passing pink urine. Can you tell me the drug which is iron chelator? I think I've given you sufficient hints here, right? The answer would be deferoxamine. So whenever you read about, deferoxamine, you will be noticing that there would be pink urine described for the patient. The second important cause is from pediatrics, and this description is written in pediatrics as pink diaper syndrome. You see, normally when a baby will pass urine and you are gonna dip the nappies of the child or the diaper of the child in water, the stain of urine will go away. I mean, the urine stain with respect to baby's urine does not stay. You dip it in water, forget about putting even salt and detergent, the stain will go away. But here the mother is saying, sir, whenever the baby passes urine, we always notice a stain subsequently when the urine tends to dry up a bit. Therefore, the term used is pink diaper syndrome, and this is infection with Serratia macerans. Then is causes for passage of a red color urine. I have already sensitized you to the fact that beetroot is something which is very simple and straightforward, so obviously will not be asked in the exam. They will ask you about the drug and do not answer rifampicin. Your answer would be rather clofazimine. The next disorder to be thought of is porphyria, and then is even myoglobinuria. In myoglobinuria, you can differentiate from hemoglobinuria because the redness tends to disappear after a while. If he says black color urine, I'm not talking about black on air exposure. If I say black on air exposure, then it's obviously homogentisic acid oxidase deficiency. Then it is definitely talking about alkaptonuria. But I just mentioned black color urine, and it would look outrageous. Black color urine being passed by a person. The diseases where you are having intravascular hemolysis like paroxysmal cold hemoglobinuria, or in PNH, paroxysmal nocturnal hemoglobinuria. In PNH, rather, the first urine sample is very dark, almost going towards brownish black. But then subsequently, as person has tea, coffee, water, then the urine color will gradually keep on becoming lighter. So there is a possibility that they might give you an image-based question in which multiple bottles having urine sample will be present. First sample will almost be bordering on black, but then it would be less black, brownish, cola colored, and then maybe become clear. So if the urine sample is gradually becoming clear over the day, it implies that the person could be having presence of PNH, that is paroxysmal nocturnal hemoglobinuria, which is discussed separately in the hematology section. If he uses the word cola color urine, then this again indicates glomerulonephritis. Glomerulonephritis will always be having hematuria to either more than 100 RBCs in a single sample per high power field, or more than 5 demonstrated at least 3 times. Can you tell me, by your knowledge of pharmacology as well as, let me say, biochemistry, in patients of alkaptonuria, because the urine will turn black on air exposure, and the patient says, sir, it really looks outrageous that I have passed urine and the sample is looking black when he's passing urine also. He says, sir, can't you do something to prevent it from turning black? So what treatment do you give? Obviously in alkaptonuria, the treatment is nitistone that you study in, even in pediatrics, and obviously in biochemistry. But one drug that can be used to mitigate the coverage, or the, I would say, to mitigate the suffering of the patient from the emotional perspective that urine is looking black when he's urinating, then we can be giving vitamin C to this patient, and this reduces this urine from turning black on air exposure. So these are a couple of details with respect to the color component. And coming towards the end of the discussion, I would also like to utilize next few precious minutes to talk about presence of casts in the urine. There are 4 of them which are to be remembered. That would be hyaline casts, RBC casts, WBC casts. Then you also read about muddy brown granular casts. And then there are 2 more terms I can say. One is broad casts. In fact, out of all of these, you guys tell me, when do you have WBC cast? And please do not answer pyelonephritis. I mean, even a second year medical student can answer that in acute pyelonephritis and chronic pyelonephritis, you could be having WBC cast. I assume that you've already studied pathology. So can you tell me a cause apart from acute and chronic pyelonephritis where WBC casts are present, while I am jotting down a bit of information here before you? Yes, guys. WBC cause can be found in patients of acute interstitial nephritis. In the earlier part of the discussion, remember I had talked about even eosinophiliuria for acute interstitial nephritis, where I said AKI could be after administration of antibiotics. So at the moment, I want you to remember additional fact here, that is WBC cause. And obviously, I mean, pyelonephritis and chronic pyelonephritis, that would be child's play, and that would definitely be not asked in the exam. For RBC cast, it is always going to be acute glomerulonephritis. Hyaline casts are a normal happening. They could be present in urine of a normal individual also. What are they composed of? They are composed of uromodulin, which is also called as TAM phosphoprotein, which is synthesized from the cells of the ascending limb of loop of Henle, that is the TAL component. And then he can ask about muddy brown cast, that would be in acute tubular necrosis. Broad casts and granular waxy cast. Granular vesicasts are very non-specific. They can be seen with chronic glomerulonephritis, but broadcasts, if he ever says the word broadcast, what is happening is that some of the glomeruli and the tubules are damaged and the remaining ones will enlarge to take over the function of the damaged part of the kidney. So this is something which is definitely useful for patients of CKD, especially one of the important causes of CKD which is to be remembered is diabetic nephropathy. In fact, one of the most important causes why chronic kidney disease can occur is diabetic nephropathy. So broadcasts are to be remembered here. So out of this entire discussion, I would say that AIN is to be remembered, then broadcast for chronic kidney disease is to be remembered, and the remaining part is, I would say, child's play, and you very well know that from pathology. It is unlikely that he will ever give you an image where in the urine specimen you would be expected to pick up RBCs versus WBCs, but then one simple hack is that when it comes to RBCs, it would be a refractile body uniform, whereas in WBC you will definitely notice some I would say speckled appearance present, primarily because like a neutrophil will be having granules present, neutrophil will be having multiple nuclei present. So rather I would say instead of a very uniform and a clean appearance which is present here, what you would be having is a fairly untidy appearance with respect to WBC cast. And anyway, I mean, whenever WBC cast are present, there is infection present, there are dead neutrophils present, there is pus present, so it has to be a relatively untidy appearance. And granular vexicast, I can just say they're very non-specific. I mean, they are found in chronic glomerulonephritis, and chronic glomerulonephritis is the end point of all the various types of glomerulonephritis that you will read in pathology and even in the medicine discussion. So they do not have any diagnostic yield. Diagnostic yield is only for a couple of aspects which I've already highlighted in this particular part of the slide before you. So this was, I would say, a fairly straightforward discussion with respect to urine analysis. Yes, dipsticks are good. That's what I started with, but then they can be having some fallacies also with respect to proteinuria. So those are couple of aspects that I would like you to remember. So keep learning, guys, keep the focus on, keep on learning new topics every day, and as you keep on upgrading your knowledge, you would definitely be able to crack questions with a higher strike rate. I mean, initially first time when you are gonna be attempting the Q bank, you might be getting maybe 30, 40, 50%. Don't be disheartened. That's what happens first time. But when you are gonna attempt for the second time, you listen to the discussion, attempt the Q bank immediately after it, and when you're gonna do this for the second time, right, that's what I'm going to call as a first read, because first read is completed and then subsequently the first revision of the person is starting. You would notice that you will be able to pick up the answers relatively better. So keep on doing questions. I mean, every time you read a topic, do the questions subsequently. These would be inputs from my side at this particular juncture. Thank you for your patience and hearing me out.